Hi everyone. It is a pleasure to welcome you today and introduce IAM Academy, a platform from Animalia dedicated to sharing, learning, and connecting. IAM Academy has been created with a simple yet meaningful goal to bring together knowledge from the lab, the field, and the public health. By fostering collaboration across these areas, we aim to break down traditional barriers and encourage a more integrated approach to knowledge exchange. We believe that real progress happens when these three worlds come together as in one health concept. Through this platform, we hope to inspire dialogue, promote innovation, and support community committed to advancing science and health for the benefit of all. Today, we are thrilled to welcome Brigitte Traveria. Hi, Brigitte.
Hi, Ariana. Yeah.
Brigitte is an equine veterinarian specialized in lameness, sports medicine, and rehabilitation. She is currently undertaking a residency with American College of Veterinary Sports Medicine and Rehabilitation, and she is certified by the International Society of Equine Locomotor Pathology, reflecting her strong commitment to continuous education and excellence in equine locomotor health. She holds a degree in veterinarian medicine from the Universitat Autònoma de Barcelona, complemented by advanced postgraduate training in equine physiotherapy and rehabilitation from ICS, from Equidinamia. She has further specialized in the diagnosis and management of lameness through Tirale and Enva in France, and she completed an internship in equine sports medicine at Equivet Veterinarios in Madrid, followed by a specialized internship in equine medicine and surgery at Clinique de Meudon in France. Sorry, my French pronunciation. Brigitte, you have a very extensive curriculum, and you are currently working in your own ambulatory equine practice in Catalonia and France through Equitop. So you provide comprehensive medical service with strong focus on performance and welfare for the horses. And you will be soon also collaborating with us in an upcoming project, right?
Thank you so much for the introduction, Ariana. It's really nice to be here with you today. Lameness is something we deal with all the time with the horses, but it's also one of the most complex things because it's rarely just one structure involved. It's usually a combination of joints, soft tissue, and biomechanics. And at the same time, our approaches are evolving quite quickly. So I'm really looking forward to sharing some practical insights and discussing what we can actually apply on the field.
Well, thank you. And before we get started, I would also like to let you know that by the end of the session, we will have time to answer some of the questions. And to ask a question, you just have to click on the bottom. There's a hand button next to the microphone. If you click it, it will turn purple. You just leave it like that. And by the end of the session, we will give you permission to ask your question and connect your microphone and camera, if you please. Okay, so Brigitte, shall we start with the first question?
Yes.
All right, so joint diseases are one of the leading causes of chronic and even career-ending lameness in horses, with osteoarthritis being especially common. We often rely on corticosteroids to manage pain and inflammation, but they do come with potential side effects, right? From your perspective, how should we approach these cases today, and what emerging or alternative treatments do you think show real progress?
So for me, if we look at equine osteoarthritis today from a clinical point of view, the main shift is that we should no longer approach these cases as joints to inject, but as multifactorial whole joint disease processes that requires a structured plan to treat them. So first, everything starts with a good diagnosis. That means not just confirming the joint as the pain source, but understanding what component of the joint is driving the clinical picture. So if it's synovitis, subchondral bone pain, cartilage degeneration, capsular fibrosis, or just a mix of these factors. The response to treatment, whether it's corticosteroids or alternatives, depends heavily on that distinction for me. So Corticosteroids still have a clear role, particularly in cases where synovitis and inflammatory pain are dominant. But it's important to emphasize that the potential deleterious effects of corticosteroids are dose and frequency dependent, as well as influenced by the specific molecule that we are using. For example, triamcinolone remains the most favorable option in many joints due to its anti-inflammatory efficacy and relatively better cartilage safety compared to others like methylprednisolone in experimental models. However, we need to be more strategic than we were historically, meaning that we should avoid routine and repeated injections without reassessment. We should be cautious in high motion joints with advanced cartilage loss and consider systemic effects, especially in horses at risk of laminitis. So in practice, corticosteroids are yet best used as a target anti-inflammatory tool to reset the joint, but ideally to allow implementation of a rehabilitation program, not as a long-term strategy. And what we are seeing more and more in practice is a shift toward orthobiologics therapies, like PRP, for example. The evidence for PRP is reasonably supportive, with the studies showing improvement in lameness and synovitis, but its main advantage is modulating the inflammatory environment rather than suppressing it. Although there is yet variability between preparations and this remains a limitation. ACS, autologous conditioned serum, and APS, autologous protein solution, are also increasingly used. Both treatments are targeting cytokine pathways, especially interleukin 1, making them well aligned with the osteoarthritis pathophysiology. So clinically, ACS is mainly used through IRAP systems, while APS is used like prostrate, and this combines anti-inflammatory cytokines with platelet-derived growth factors. They are really particularly useful when repeated treatments are needed or when we want to reduce corticosteroid use, as we mentioned before. There are other options like mesenchymal stem cells, which are promising from a disease-modifying perspective, but variability and lack of standardization is still a limit for a routine use. There's also the polyacrylamide hydrogel, which is gaining traction as a longer action option. It seems to improve synovial function and biomechanics, and some studies sustain an effect over 1 to 2 years. So it's quite interesting. And beyond these kind of therapies, we have also other ones like bisphosphonates, which are really useful too to treat subchondral bone pain, which is a significant component of the lameness. This kind of treatment works by inhibiting osteoclast activity, and they help modulate bone remodeling. And this can have, we've seen that they have a really good impact in conditions like navicular syndrome, but we realize more and more that we can use them for other pathologies like neck pathologies or back pathologies too. There are also supplements containing some kind of mild anti-inflammatory properties, like as arpagophyton, and this can be really useful to support the initial therapy, not as a main therapy, but just to complement it. And even though all these therapies, it's important that none of these therapies will perform optimally without addressing the biomechanics and the workload. So we must have in consideration corrective chewing, appropriate exercise prescription, and controlled return to work as a critical aspect of these therapies. In many cases, failure is not due to the drug choice, but due to the persistent overload of the affected joint.
Okay, so like to sum up, these therapies, there are some innovative therapies that still need some research, but so far they need to be complemented with other therapies like biomechanics and workload, etc., in order to work better, right?
Yeah, exactly. I mean, it's important to choose the right therapy, but to do all the rest in the right direction too.
Exactly. There's not a gold standard therapy yet in this sense. Okay, second question. Platelet-rich plasma has become one of the most widely used regenerative treatments in horses, especially for tendon injuries and osteoarthritis, as you mentioned. Based on the latest research studies show variability, you already mentioned that as well, and also lack of standardization protocols. In your opinion, how effective is PRP, and what are the main limitations we still need to overcome?
So for me, PRP is certainly one of the most widely used orthobiologic therapies, but the evidence is still quite heterogeneous. Some studies report improvements in lameness or even healing, particularly in tendon and ligament injuries, but overall the results are inconsistent and difficult to compare due to the lack of standardization of the protocols. So in my own practice, I don't use PRP routinely. I tend to prefer other approaches depending on the indication. For example, in soft tissues injuries, I rely more on rehabilitation strategies and modalities like laser therapy and not invasive ones. For joint disease, I more often use treatments such as IRAP or polyacrylamide hydrogel, depending on the case, which I find more consistent clinically. But one of the key limitations of PRP is precisely this variability. Difference in platelet concentrations and preparation protocols mean that PRP is not a single product, which directly impacts outcomes, and for me it's difficult to assess it. So overall, I would describe PRP as a promising option. I think all of them are promising options, but with variable and case-dependent results rather than a consistently reliable treatment.
Do you think maybe if we had like a standardized protocol and more of a standard PRP, would you maybe use it in the future, or do you prefer other options?
I mean, for tendons and ligaments, what has been seen lately is that it's better not to inject something in there.
Okay.
It has any tendencies. But for the joints, yes, I think the main issue is that it's not standardized and the studies are not really, they don't have a really good conclusion to say, okay, this is working, let's use it clearly.
Yeah, so maybe this is like a research opportunity, right?
Yeah.
Okay, so we mentioned this variability, but we also need to like consider the variability from horse to horse. How do factors like age, breed, or how severe the injury is affect how well these treatments work in practice?
That's a very important point because one of the main reasons for variability in outcomes with this kind of therapy is precisely the individual characteristics of the horse and the lesions. There's age, for example, which play a significant role. In younger horses, we generally have better healing potential. So we are more, we use more often this kind of regenerative therapies, especially with these young horses. But with older horses, we have usually a chronicity of the lesions, and this makes the lesion a little bit more difficult to treat with these biologic therapies. Even though we can try to use first a corticosteroid and then try to apply this kind of treatment, but the response it's not the same one. And other factors that can influence its breed and discipline. discipline can also influence these results, mainly through biomechanics and workloads, because each discipline has his own biomechanics. For example, racehorses or sport horses are exposed to very high repetitive loads, which can negatively impact healing if the rehabilitation and load management are not optimal, as we said before. So, and I would say that beyond these factors, one of the most critical elements is actually the environment we create after treatment. As I said, I insist rehabilitation and control exercise. It's the most important thing for me, because even with the best biological therapy, if the mechanical load is not well managed, the result will be limited. So overall, these treatments are not one size fits all, because each horse reacts differently. Even with the same lesion, we have different responses to treatment. It's the reason why it's so difficult to objectify.
Yeah. One question. You mentioned the breed also influences how the outcome of this regenerative therapy will respond. Is it because of the metabolism of these horses, or why is that?
I would say it's more related to the discipline, because we use some kind of breeds for some kind of discipline. So I wouldn't know how to differentiate one from the other. I would say it's more because of the load of the discipline, which is different in the dressage horses and for example, show jumpers.
Okay, thank you. And when it comes, well, you have all this variability, right? So do you have like a standard protocol that you follow in order to choose good candidates for this treatment or that treatment, or do you go case by case?
I mean, it's very case dependent, but the key factors are the type and stage of the lesion. As we said before, if there is a subchondral bone pain or cartilage damage or just synovitis, it's kind of important for to me to choose. And then I also consider the horse itself, the age, the use, and the expectations that the owners have, because this is
of course
important. And realistically, the owner's budget, it's a main issue to choose one treatment or another, because these therapies can be costly and often requires repetition. So corticosteroids are for people who doesn't have the budget, the easy choice in joint pain, lameness. And one of the most critical aspects is whether we can control the mechanical environment after the treatment. If they are not willing to do what it has to be done after the treatment, I mean, it's not really useful to use this kind of therapies.
Yeah, exactly. A little bit like us humans, right? When we go to the doctor or physiotherapy. That's right.
Exactly.
Okay. So now focusing a little bit on research. Research has shown that pro-inflammatory and catabolic cytokines like interleukin-1 beta, TNF-alpha, and interferon gamma are present in injured tendons and ligaments, but not in healthy horses. This should suggest that they might be driving ongoing inflammation and tissue breakdown. So from your perspective, how does this understanding change the way we should manage tendinopathies in horses? And do you know if there are any treatments targeting these pathways that show real promise?
Yes, I think this has really changed how we approach tendinopathies. We now see them not just as a focal mechanical injury, but as a combination of mechanical overload and dysregulated inflammatory environment affecting the tendon more globally, not just the lesion site. In practice, this has led to a more conservative and structured approach, with a growing tendency to avoid repeated intralesional injections and to focus more on controlling the biological environment and mechanical load. So it's something we also see in human sports medicine now.
Okay.
It's also important to remember that we are not just treating a lesion, but the entire tendon. Even the healthy part is often structurally and functionally altered. So rehabilitation and progressive loading are essential to restore the whole tendon, not just the injured area. And in clinical practice, before they used to treat only the lesion itself with this kind of therapies, which can maybe change the results. In terms of therapies, orthobiologicals like PRP or ACS aim to modulate cytokine activity. All the results remain variable. Again, in my practice, I rely more on physical therapies, such as laser, which is quite promising.
Okay. And when it comes to all these injuries, like tendon and ligament injuries in horses, as you said, like healing can be incomplete sometimes because the treatment does not work, or maybe the owner is not fond of doing all the rehabilitation and all the other things that you proposed. So re-injury can be a major issue, right? When this re-injury happens, I believe that for the formation of fibrous tissue happens, and this limits the architecture of the joint. So stem cells have been used as a way to truly regenerate tissue rather than just repair it. How promising is this approach in your practice today? Have you had the opportunity to use stem cells therapies?
Yeah, I think stem cells are still promising, but in my practice, I don't use them routinely.
Okay.
One reason is that the protocols can be quite complex and not always practical in the field, and there is still lack of standardization. And also, although they are generally considered safe, some clinicians have reported local reactions to me, so with much more experience than me. So there's still some caution in their use for me. So overall, I think they can be really useful in selected cases. As you said, we must focus on avoiding re-injury. So, but at the moment, they are not part of my first line approach because of this.
Okay. And this question I already asked for PRP, but do you think pharmaceutical companies should invest more in stem cells or standardizing protocols, etc.?
Yes, of course. I think pharmaceutical companies should continue investing in this area, but maybe with a different focus. Don't need new products. I think the ones that we have, they are good. We just need to standardize protocols and have studies that prove that this is working if we do it this way with this rehabilitation program and in this kind of horse. I think these protocols clearly defined are going to help us more than new products that we don't know.
The outcome, yeah, of course, I understand. All right, now a question about the interleukin-1 receptor antagonist protein, which is abbreviated as IRAP, okay? So the IRAP therapy uses a horse's own blood to produce anti-inflammatory proteins that target joint inflammation, right? How does IRAP compare to more conventional therapies like corticosteroids or hyaluronic acid injections? Are there scientific gaps that research should be focusing on?
Yeah, I think IRAP is interesting because it targets this interleukin-1 specifically. So it's more focused than corticosteroids, which remains more predictable and faster for clinical relief, but it's not the same risk kind of result. And compared to hyaluronic acid, it probably has a stronger anti-inflammatory effect. But in terms of research gaps, there are still several important ones. First, the lack of standardization again. There are different systems which produce very variable cytokine profiles, so results are not always comparable. And second, we still lack strong, well-designed comparative studies against corticosteroids. I mean, we know that corticosteroids have a proven effect, but we need to compare them to assess objectively and to let the owners know, because finally the decision is theirs. And yeah, we, as I said before, we need to know in which cases this kind of treatment is better to be used compared with corticosteroids, for example.
So maybe like in preclinical study, we would use corticosteroids as a reference substance that we should compare with the IRAP, for instance, and we should get at least the same result as corticosteroids.
Yeah, I would say.
Otherwise, the best option at the moment is still corticosteroids. Okay. And about hyaluronic acid is often used to treat joint issues in horses with osteoarthritis, but can it also be used preventively to protect joints before we develop them, like the horses develop them, or is it mainly effective once horses' lameness or osteoarthritis is present?
Hyaluronic acid has traditionally been widely used for joint disease, mainly to improve the synovial environment, so mainly not alone. It's usually given with the corticosteroids at the same time in some practice. So partly because some clinicians reported local reactions in the past, but also because in many cases the clinical benefit is not clearly superior to other options, especially when used alone. I think it's not as used as it maybe should be. And there is also very limited evidence supporting its use as a preventive treatment in some horses. So today I think to see hyaluronic acid more as an adjunction therapy rather than a primary or preventive treatment.
Okay. Do you use it in your practice?
No.
Okay. And another question, what kind of local reactions have these fellows of yours reported?
A huge synovitis and inflammatory response in the joint. I mean, I think this is no longer happening with the new hyaluronic acid products. It was reported a few years ago, but the effect is not clear since it's almost given with corticosteroids at the same time. We haven't seen a difference between corticosteroids alone or corticosteroids with hyaluronic acid, or a clear difference.
Right. So in the end, hyaluronic acid cannot be used as preventive. And you also said that they, maybe not now, but they used to cause local reactions. Are there other side effects that we should consider?
Not to my knowledge. I would say this is the main one. But it's true that when you inject a joint and with a preventive objective and you have a huge inflammation and reaction, the owner
doesn't like it.
Be really happy because it wasn't needed. So, I mean, it's usually easier to treat a joint which is in need to be treated than just want to prevent it.
All right.
I would say.
Right. Studies on PRP show a lot of variability. We already covered that. But also not only from horse to horse outcome or from product to product, they also show variability in platelet and white blood cell concentrations. So in practice, I think you said that you don't normally use PRPs, but if you do, how do you make sure that you meet the right standards for treating horses effectively?
Yeah, as you said, I don't use it in my current practice, but when I did or when I've seen it used in different clinics, the key point was really to follow a structured protocol as described in the literature, even if they used different ones. They were, it's in racehorses in the north of France. It's really used in place, so just they take the sample and centrifugate and inject at the same time. Others just do some more elaborated preparation. But I think the main thing is to do it the same way, in the same practice. And also the other important thing is knowing the timing of the injection and the number of treatments that you need to do in your rehabilitation program.
Okay. And something that we also talked a little bit, when limb pain becomes chronic in horses, is not just about the injury itself, but the whole nervous system itself can change, right? So for instance, it has been documented that neurons can change their anatomy and physiology. So in everyday practice, how do you manage these cases, and what tools or treatments do we rely on?
Yeah, exactly. When limb pain becomes chronic, I stop thinking only about the original lesion and I start thinking about the whole pain system. In those cases, I first try to control any ongoing nociceptive source, and often with systemic anti-inflammatories if indicated. But then the key step is the rehabilitation with good physiotherapy, progressive exercise, and treatment of the compensatory muscular problems. I think this is really important nowadays. And because once the local injury improves, we also need to help the horse recover normal movement pattern. We have to see the whole thing.
Okay. And now, just to sum up a little bit, because we already mentioned that a little bit, from all these regenerative medicine in horses, what are the main limitations and adverse effects that maybe the vets, the clinical vets, or the owners should be aware of?
So mostly for the owners, I think they must have clear that we can have adverse effects like a mild or a local inflammation or post-injector flare, which is a huge inflammation. In some cases, reported reactions depending on the product. Another limitation is that the results are not always predictable. It depends on the case selection, the timing, and the rehabilitation, as we said. And finally, the cost and logistics can be a factor for vets and for owners, because sometimes we must do the treatment in place at that time, and some of these options are not possible. So overall, these therapies are useful tools, but they need to be used carefully and with realistic expectations and as a part of a structured treatment plan.
And do you see the use of this type of medicine like really often in practice, or is it like something that it's being used more and more on a daily basis?
Yeah, I think it's more and more used because even owners are demanding this, because which is difficult for me. It's sometimes owners are aware that corticosteroids are working, so now we have to let them know that the other options are working too, and they have a good point to be used. And this is what it's difficult to change mine. It's well known in other countries. In Spain, I think we need to work.
Yeah, things sometimes are difficult in Spain, right?
But yes, we use quite often IRAP and prostrate, and yeah, it's more and more used.
Okay. Well, Brigitte, thank you so much for your time. If there is one key message you would like listeners to take away from today's discussion, what would it be?
I would say there is no best treatment. Most treatments can be useful if they are well understood and used in the right context for the right horse and at the right time.
Okay, thank you. And before we wrap up, I don't see that there are any questions from the audience, but if anyone has a question for Brigitte, that would be the time to do it. Just remember that you need to click on the hand button next to the microphone, and we will give you permission to ask the question. Okay? Well, I don't see any questions. So a huge thank you, Brigitte Traveria, for joining us today and sharing your expertise on horse lameness and treatments. It has been an interesting conversation, really, and I hope our listeners enjoyed it as much as I have. So, Brigitte, thank you so much for helping us kick off the 4th episode of Academy. And looking ahead, our next session will be on June 1st, featuring Maria Jose Clavijo, and we will discuss different bacteria that cause fibrinous polycerasitis in pigs. Okay, so see you in the next episode. Thank you, Brigitte.
Thank you, Ariana, and thank you, I am Animalia.
Bye.
Bye.